Welcome to the 14th edition of the Social Service Workforce Webinar Series, which is brought to you by the Global Social Service Workforce Alliance through funding by PEPFAR USAID and supported by Capacity Plus. My name is Florence Martin and I'm the Senior Policy and Knowledge Management Advisor for the Better Care Network. For those of you who don't know the Better Care Network, we're a global network that facilitates active information exchange, research, collaboration on the issue of children without adequate family care. We're really delighted to be co-hosting this webinar in collaboration with the Global Social Service Workforce Alliance. So today the topic of our webinar is the deinstitutionalization of alternative care systems for children, a process that is ongoing in virtually all regions of the globe today. And we will discuss the implications of this process for the social service workforce. We're going to be hearing a presentation focusing on the experience of two countries where care reforms and the institutionalization processes are ongoing, but also are at different stages, Rwanda and Moldova. So a brief introduction about deinstitutionalization before handing over to our presenters, and trying to remember as well to put the agenda. Over the last 30 years, there's been a growing understanding of the negative impact of institutional care on children's development and well-being, and the recognition of the critical importance of the family and the family environment for children. This legislation is at the core of the Convention on the Rights of the Child, adopted in 1989, and more recently also in the guidelines for the alternative care of children, welcomed by the United Nations General Assembly in 2009. Reforms of alternative care systems for children deprived of parental care have been ongoing in all regions, with efforts to deinstitutionalize the system, moving away from the use of residential care, particularly large-scale institutions, and putting in place a range of alternative care options for children that are family-based through the child and extended family with kinship care, or an alternative family care option through foster care and adoption. So these reforms have been informed as well by research that has shown that the vast majority of children in residential care are not placed there because care is actually needed or genuinely needed, in other words, that they are without parents or family care, but rather because their families are facing a range of challenges in caring for them, including poverty, lack of access to social services, personal or social crises or emergencies. As a result, a major focus of the shift away from the use of residential care for children is not just about reducing the number of institutions and removing children from there, but also about better preventive and family support services to stop children going into alternative care in the first place. Are you all having trouble understanding me? I'm going to try to speak. Yes, I am, yeah. Do you want me to try again? Okay. I can try. Okay. I'm trying. Is that better? Okay. 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 Thank you. Okay, I'm sorry you've not been able to hear me. Basically, just a short introduction on deinstitutionalization, pointing out that The process of transforming care system and moving away from the use of residential care and focusing on child and family-based services has been ongoing across the globe, and in a range of country contexts. They have been undertaken in all high-income countries, including in Western Europe and North America, where institutional care used to play a major role in the child welfare system in those countries. And more recently, they have also been taking place in middle and low-income countries, from Central Eastern Europe and Central Asia to Southeast Asia, Latin America, and Sub-Saharan Africa. So a growing body of learning is being produced about what deinstitutionalization entails in this varied context, including the important implication of this transformation to the social service workforce in each country. This shift towards more family-based care and preventive services has major implications not only for the staff and the management of the institution, but also for the social workers, the community workers, and the staff of the local authorities who are to establish, deliver, and oversee child and family-centered services. So today we are very excited.
Thank you very much, Florence. Hello, everyone. Good morning, good afternoon, good evening. Please let me know if the sound is reasonable, and maybe Chris can help me. Perfect. The PowerPoint is now up. Thank you very much for your introduction, Florence. It's a pleasure and a privilege to be part of this webinar. It is a great pleasure to be able to speak from my experience in the institutionalization of open homes for children, but also to focus on an extraordinary example of reform in Rwanda. My presentation will focus on two different components. I will try to sum up our learning in terms of deinstitutionalization, the process, and how this process actually feeds into the development of the capacity of the social workforce, and further how this process is raising awareness and increasing the capacity of families and communities to stay together and not to rely on institutional care. The organization that I represent, Open Homes for Children, is a organization with about 20 years experience working across Central and Eastern Europe and Africa. Our work is based on the fundamental recognition that the child, for the full and harmonious development of his or her personality, should grow up in a family environment in an atmosphere of happiness, love, and understanding. We have sufficient evidence today, both historical and very recent due to advances in neuroscience and genetics, that institutional care and generally adversity, especially in the early years of life, leads to developmental delays, leads to economic disparities, leads to immediate, medium, and long-term consequences on children, but not only on families, communities, and societies. Our work and our vision is simply of a world in which children no longer suffer institutional care, and we have been true to this word, trying to implement deinstitutionalization in partnership with other organizations and governments to reform child protection systems that rely on institutional care. We have experience of working in 15 countries, and most recently our experience in Rwanda is, I believe, worthwhile sharing. Irrespective of the context in which we operate, either Eastern European, African, Latin American, the reliance on institutional care looks very much like a sequence of events that lead to separation and placement in institutional care with long-term consequences. The pattern is extremely similar. Families at risk experience a range of risk factors, hardship, unsustainable source of income, marginalization, ill health issues, lack of access to basic services, poor family and social relationships, they lack parenting skills, they might be displaced, or they experience the loss of one or both parents. These families are at risk, but in a system that only relies on institutional care, there is absolutely no intervention, no action at this level. Therefore, risks who might have been addressed relatively easy or even more complex, but with a targeted and finite intervention, lead to chronic problems and to crisis situations. Unsustainable source of income transforms into loss of income, loss of housing, discrimination, ill health issues lead to disability, lack of medical support, welfare assistance, families break down, and parents' capacity to provide adequate care to children reach a critical level. Again, reliance on institutional care leads to children being separated, because the lack of action turns into a crisis situation where the capacity to intervene and actually to achieve positive changes in a relatively short period of time is reduced. Children are separated from their families with devastating outcomes. It's not only that the trauma of separation takes place, but also the solution, the cause of the problem is really not really addressed. We have piloted, implemented, and worked through a model of change that enables us to resolve this sequence of events and transform this problem into creating a child protection system that does not rely on institutional care and puts emphasis on supporting families, on preventing separation, and providing adequate family-based care to children who need that type of support. Our model of change is very simply represented in this pictorial, and I want to highlight the three interconnected levels. The first one, and our approach, is really to target the level of institutional care. And I would say target that level with an aim to close institutions, but to close institutions not in the sense of closing the buildings, but really eradicate that form of care through the development of prevention, family support services, and family-based alternative care. Interlinked is the second level of capacity building for the social workforce, which is absolutely critical in enabling the family support and strengthening services, as well as the family-based alternatives, to function to the highest standard. Last but not least, in this model of change that has been used and implemented across many environments, changing the policy, the legislation to shape up and complete and strengthen a child protection system is absolutely critical. Using this model of change, you can very much, if we go back to that slide which represented the reliance on institutional care, the model of change really helps completely transforming a child protection system that is based on institutional care in a child protection that is supple, is actually adequately resourced, and most importantly is focusing at addressing the risks at family level, strengthening communities and their ability to respond adequately and timely to prevent separation. This new child protection system developed has very strong gatekeeping mechanisms that enable both access to services, adequate services, timely services, but also help allocating well community resources. With such a gatekeeping mechanism in place, not only that we achieve great success at family and community level, but we reduce dramatically the number of children that might need a formal type of care, which then can be provided at high standards, high quality, in a family-based alternative as recommended by the UN guidelines. For this system to function, building the capacity of the social workforce is absolutely essential. And in the second part of my presentation, I will focus on how we can how deinstitutionalization and the implementation of this process enabled us to identify the key levels of intervention, to identify the key elements of knowledge and skills that were required in order for us to achieve a transformed and reformed child protection system that is modern, adequate, supports families and communities, and does not rely on institutional care. In the second part of my presentation, I will really highlight the importance and the example of our work in Rwanda. And I must start this with really highlighting the role that the Rwandan government plays in not only committing, but developing and creating an amazing vision for the children in the country, and the leadership role that the government has in taking deinstitutionalization and using it as an engine for child protection system reform and development. We keep using this word, deinstitutionalization, and one is very difficult to pronounce. Second, you probably can estimate the numbers of years experience in the field in deinstitutionalization if someone can pronounce it as quickly as I do. But unfortunately, we do not understand necessarily the same thing. So I would really like to clarify what we understand by deinstitutionalization, and I think the slides before presented you a little bit the process behind. It's not about closing buildings. It's really the process of replacing institutional care with a range of family strengthening and prevention services and family-based care services. And it's really a process that helps us to embed the two fundamental principles that lay at the foundation of the UN guidelines on alternative care, the principles of necessity and suitability. In partnership with the Rwandan government, with the National Commission for Children, who has a leading role in the development and the reform of the child protection system in Rwanda, and of course in partnership with a number of other organizations, UNICEF, Global Communities, Tulane University, and supported by a range of donors. I'm always worried to mention few because you always forget someone, so apologies if I forgot anyone. We have developed and engaged in a transformational process in the country. I would like to put this work on deinstitutionalization and capacity building in Rwanda in the context of the Rwandan steps which build up the national context to the level where the deinstitutionalization became a clear priority for the strategy. I will just mention few critical milestones. In 94 until to 98, in Rwanda, foster care unification and reintegration efforts happened on a large scale as a response to high numbers of unaccompanied children and orphans post-genocide, but also rapid establishment of residential facilities. And I'll give you an insight on the development of institutional care in Rwanda in few slides. In '96, the government declares One Child, One Family campaign on Day of the African Child to promote family-based care. In 2003, the National Constitution of Rwanda was adopted. In 2007, the law number 1 related to the protection of persons with disabilities was approved. In 2008, there is a national strategic plan for orphan and vulnerable children covering the period between 2008 and 2012. In 2010, Hope and Homes for Children, my organization, we signed a memorandum of understanding with Niger-Prof, and we began piloting deinstitutionalization in the country, really focusing on one institution with a view to demonstrate how deinstitutionalization and capacity building can be implemented in the national context. And since then, in 2011, an integrated child rights policy was approved. The Law 22 and 54 establishing the National Commission for Children, a central authority affiliated to the Office of the Prime Minister and under the authority of the Ministry of Gender and Family Promotion, really a national body which oversees and coordinates all children interventions in Rwanda was created. Law 54, the Law on Rights and Protection of the Children, the adoption of the Strategic Plan for the Integrated Child Rights, and then, of course, the National Strategic Plan. In 2012, the Hague Convention for the Protection of Children and Cooperation in respect of inter-country adoption enters into force, and the Strategy of the Child Care Reform commenced being implemented, included a critical project Tubarere Mumuriango, Let's Raise Our Children in Families, or in shorthand TMM, in case I will refer back to the name. The aim of the strategy in Rwanda is to really transform Rwandan current child care and child protection system into a family-based, family-strengthening system whose resources, both human and financial, are primarily spent on family preservation, family prevention of separation, and then provides adequate and timely support for children without parental care. I would discuss in more detail the process, but I wanted to also share with you the very simple steps in which we can simplify the very complex process of deinstitutionalization and capacity building. Engagement, assessment, design and development, transition and monitoring. On the right-hand side, you have a proof that I'm no artist. On the upper drawing represents a district or a province, and the green dot is the institutional care facility. The drawing underneath is what the institutionalization can achieve. Through the institutionalization, the centralized one solution fits all production line institution is really replaced with a range of community-based services, with a range of supports that are geographically located and spread across the area, therefore enabling all families to have access to them. Let's talk a little bit about the situation of children in institutional care. As I mentioned before, in partnership with the Rwandan government, with NCC, with UNICEF, global communities, and all our other partners, we work together to implement the national strategy. And we really understood the importance of having a solid baseline. In order to achieve that, we implemented a national survey, which gave us an extraordinary insight into the institutional care system in the country, both in terms of who are the children and why they're there in institutional care in Rwanda, but also in terms of what kind of resources are locked, are trapped in the institutional care system that we can use in order to create a system that is not relying on residential care. The national survey, collecting information relevant to up to the end of 2011, highlighted the fact that there were over 3,000 children and young people in institutions, about 33 institutions, those excluding institutions for children and people with disabilities, almost a similar proportion of boys and girls, a huge age range between 0 and 43 years old, with almost 30% of the children spending more than 10 years in institutional care. Also, we identified the fact that in those institutions, the level of information was extremely poor, but looking at the reasons for placement, we identified that children were placed because in most of the cases because the death of one or both parents, abandonment, but it wasn't defined, and of course because of poverty. Now, why this information is relevant, it is absolutely critical for the element of capacity building, because it tells us who are the children in the institution, and I want to point out a high proportion of children under the age of 3. So automatically we identified that as a key target group, both for prevention as well as for support for transitioning out of the institutional care system, but also a very high proportion of young people. The data at the institutional level also highlighted the entry points into the system. Children were referred by parents, by their close relatives. So there was a contact, and we immediately identified a key level of intervention. Of course, children were also referred by the local authorities. The average time in institutional care was 13 years. Therefore, comparing it with any other system, it went all the way up to the higher limit, and highlighted the fact that once in an institution, the children had no plans in place, and there were no efforts made for children to be able to reconnect and return back to their families. Even with very poor record keeping, and in a relatively short period of time, we managed to identify that about 33, maybe 34% of the children were in contact with parents and relatives, whilst about 50% were not. As I said before, this type of information gave us tremendous insights both on the key levels of intervention for capacity building, as well as on what kind of knowledge, what kind of key information we need to provide at those key levels to enable the development of the institutionalization. The shift from thinking that institutional care is actually a good resource and a way to support children to a mentality where institutional care is not used. So obviously we identified that it was very important for us to commence targeting individuals, parents, relatives, people living at community level, to engage with local leaders, volunteers, professionals, and paraprofessionals working in health and education because of their direct contact with children, and to target specifically the district, provincial authorities that are and were responsible in referring children to institutional care, as well as the general public. The three key chunks of information, if you want, that we immediately identified as essential to commence the capacity building in these groups were very much around the general awareness of the harmful effects of institutional care on children, families, and communities. The alternatives, yes, there are alternatives. Institutional care does not need to be used. And then it also, we identified how important it was for us to enable these key stakeholders to be able to connect and map the community resources at local level with a view to develop a coordination mechanism. The same survey gave us a very interesting glance into the capacities and the resources that were locked in the institutional care facilities in Rwanda. The first institution was built in 1979, most recent in 2010. Over 50% of the institutions were established by faith-based organizations with a size ranging from 8 to 566 children. Total number of staff employed in institutions, 599, with a tremendous age range, 15 to 75 years old, and you see what was the declared education level. We also had an insight on the financial resources available at institutional level, but only 23 institutions identified and were transparent enough to share their financial information, their finance being mostly private, with of course some contributions in certain cases from the Rwandan government. About $5 per child per day was the average spend. What kind of indication and implications this information had on our planning for capacity building? Well, obviously we identified the importance of targeting professionals and paraprofessionals, non-specialists though, at certain key levels. The local authorities, especially those involved in referral and placement of children, professionals across health, education, NGO, working and involved in various types of service provision, the staff in institutions, and then, of course, at national level, we identified the importance of the National Children's Commission to a Commission for Children to strengthen its capacity to be able to coordinate all these levels. The type of information, the skills, the knowledge that we identified as being critical to building the capacity at these levels was a step up from the general information identified before, and let's say it was a little bit more technical. Nevertheless, pretty much along the same lines. The importance and the knowledge of the harmful effects of institutional care, the alternatives to institutional care, including the UN guidelines on alternative care, the community child protection networks, and gatekeeping. Going further, we identified which children are in institution and why. We identified, therefore, which are the entry points and where our efforts for capacity building should start. We identified who are the key players, professional, non-professional, that are involved in both working with children, referring children in institutional care, and therefore themselves being able to participate into the deinstitutionalization process and then continuing to be part of a competent general social workforce supporting the child protection system in Rwanda. But we also identified with our partners that there is a clear gap, and that was a dedicated professional social workforce with skills and capacities that will enable and to assist children to transition out of institutions, to prevent other children from being placed in care, and to support prevention, case management, alternative care provision, and post-placement support. These professional workforce really, for us at that point in time, represented the glue connecting all these elements from the community and family all the way to the provision of family-based alternative care. The connection from the national level of MCC all the way to provincial and district and household level. This professional workforce would really enable the implementation of the national policies and the strategy, and really help provide this integrated approach centered on achieving the best interest of the child, and also playing a critical role in driving the reform. And here again, once more, I would like to highlight the importance of the Rwandan government's decision and commitment to closing this gap and to make a significant investment in the development of a professional workforce. And in the next couple of slides, I will very quickly highlight our joint efforts with the Rwandan government, with Chilean universities and UNICEF in developing this professional social workforce that will be specialists on children, child protection and care. This initiative aims to train and specialize university graduates in social work and psychology or education to become the social workforce in Rwanda, to deliver child care and protection at subnational levels and to implement the reform. Another outcome for our capacity building efforts with this particular group were to strengthen the capacity of the local institutions and the National Commission for Children to monitor workforce performance, as well as to deliver training. So we wanted to create something that is sustainable, flexible enough, with embedded monitoring and evaluation systems, able to continue to develop and learn. We established a clear training program, and the outcomes highlighted were to increase the competence, especially on child protection issues, to increase the competence in terms of the child care system reform, and to increase the competence of the social workforce in the utilization of self-directed learning and peer support, building therefore the resilience, the learning and the growing professional growth in this program. The Rwandan government recruited the first over 30 professional social workers and psychologists, and we developed a methodology to fit this diverse and very ambitious group of professionals. We are using varied learning techniques. We are working in key partnerships with national organizations, therefore building its relevance and sustainability. Now, the program, content-wise, was divided in 7 modules, with an underlying module for professional development and professional identity. The first group of trainees will complete the training, I think, in the beginning of next year, and we will be reporting on its outcomes. So far, the process has been implemented successfully. The feedback coming from the workshops and the learning, which combine pre-service, in-service training, field work, support, professional supervision, and very much customizing the content, the theoretical content, to be relevant to the national context, enabled us already to identify the few critical success factors of the program so far. Child-centered, evidence-based, building on existing resources and capabilities. The whole approach enabled us to look not only at where the gap is, but also to look at staffing institutions and develop and engage them through training programs into identifying in which areas of the new system and at community level where they can get involved. It is definitely scalable, and we have embedded a very clear measurable indicators to measure its outcomes. Other key success factors, probably the most important, the government vision and commitment, the ability to commit for this huge investment, the interministerial coordination, and once more the role that the National Commission for Children played was absolutely critical, and the coordination between various implementing partners. Thank you very much. I hope my presentation was sufficiently interesting, and I hand over back to you guys.
Yes, thank you. Just checking, is my microphone clear? Okay, good. What we would like to do is at any time during both Florence's presentation and now and then the next presentations, if you have questions, you can write them in the chat room. We thought we would ask Florence maybe a question or two at the moment, and then we'll go on to the next presentations, and then after they're finished, we'll have a few on them, and then we'll be able to have some overall general questions. So, yes, Martha, I'm just curious that in your capacity building slides, you mentioned the need to strengthen the capacity of the social service workforce. And then you mentioned in an earlier slide that there were 599 staff members currently within the institutional context. I'm curious about how did
I'm afraid I lost the sound. I'm unable to hear the answer. I'm not sure if people can hear me. I think I might, if maybe Jim, you can type in your question. I believe that your question is around capitalizing on the existing staff in institutions and what are the plans for. Can you confirm, please? Yes, of course. I'll be delighted to talk about our engagement with staff and existing community resources. I think that you do not have first and foremost to reinvent the wheel. I think it was very important for the Rwandan government to make a commitment to bridge a gap in terms of the professional child protection specialist workforce. But 599 individuals working in institutions, they have all developed during this work a set of skills. They are there because they care, and it's very important in every kind of reform process to start first and foremost with building the capacity of institution level. And again, if you remember that slide in which I highlighted those 5 steps of deinstitutionalization, in the first one, at the engagement level, it's actually critical because you come in contact and in touch with the staff in institutions, and they are the ones who actually understand children, understand their needs, their circumstances. They have a great understanding of where the children are coming from, if they're in touch with their parents, what are their wishes and dreams. So it is a very important point for us in terms of understanding and learning more about the children, but also it's a great way to develop a trusting relationship with those who are working in institutions. And deinstitutionalization is a change, is tremendously stressful, is stressful for children and equally stressful for adults, who needs to be accompanied as well to understand what is going to be at the end of the journey in terms of their roles. And this is where our experience actually shows that it's very important to provide support and learning to the staff in the institutions and to understand where their skills could go. I'll just give you a couple of examples. There are a couple of community centers working with and supporting children with disabilities at community level, staff from institutions. Some staff from institutions has been trained and they are now involved and engaged in that level. Staff in institutions work with children, very young children that are placed in institutional care. With training and support, they could become emergency foster parents. So there are that capital can't be ignored. I think the process in terms of leading its development should start with the children and what the children need and where the children need to receive services, and then the staff in institution can be retrained to be able to provide that support. The engagement with interfacing, there is another question coming on the chat about the interfacing with the faith community, given the high percent of institutions linked with faith-based stakeholders. Indeed, private organizations, faith-based organizations that are supporting institutional care are doing it with all the good intentions, with a view to provide adequate support to children. We believe that it's absolutely critical and essential to engage with those organizations, to establish a trusting working relationship, and then to enable those to shift from supporting institutional care into supporting children and families at community level or any other community-based services. It would be a tremendous loss for us to lose their support, to lose everything that they bring, all the resources that they bring into supporting children. And in our experience in Rwanda, an open partnership, a clear explanation of why deinstitutionalization is critical, with an emphasis of why institutional care cannot respond to what children need, why institutional care is actually not enabling children to realize their best interests. And also, I would like to highlight the financial aspect of it. Institutional care is expensive and it provides very limited outcomes. Now, with the same amount of resources, you could support probably
Thank you. Hi, everyone. Can you hear me? Okay. Well, first of all, I would like to thank Florence for inviting Moldova to present this case. To inviting two of us, Stella and myself, to do it. We are honored, and for introducing us to the audience. So I will start with a very brief information about Moldova. It's a small country in Eastern Europe with a population of 3.5 million, which is declining and aging. It is the poorest country in Europe, and the most affected by poverty are families with more than 3 children, which are really struggling to care for their children. Our country is highly prone on external shocks because it's due to its dependency on external aid, especially in social protection, and due to its dependency on remittances because we have high rates of migration. So back in the 90s, what independent Moldova inherited from its Soviet past was heavy dependency of its childcare system on residential institutions. Moldova had a childcare system which was split between several ministries which did not really talk to each other. Non-existent support for families at community level, very few alternative family-based care services, social norms strongly encouraging institutionalization of children, and poverty as the strongest push factor for institutionalization of children. The challenge was to DI a well-established system which was actually functioning against the child's best interests. And this was more than 20 years ago when one could not say a D from the word deinstitutionalization. So the question was how to go about it, and the answer was by changing minds and by building capacities at all levels, both in the system and in society. This slide shows the evolution of change in alternative care and also results that were achieved. So overall, the use of alternative care is on decrease, which means that Moldova did well on prevention side. It means that less children are being separated from their families, which is not typical for all countries. The second result was that residential care is on decrease. The number of children was decreased by more than 50%, and family-based alternatives are overtaking. And that for those children who do need alternative care, family-based solutions are used twice as much as the residential ones. So thus, in 6 years, Moldova managed to reverse the picture of alternative care. It's a great result, of course, to a big extent, thanks to the efforts of the new workforce, which was created throughout the DI process, but also very much due to the external support. So it's a great result if we look at the general picture. But when we looked at it through equity lenses using disaggregated data, we could identify certain categories of children which have not benefited from the DI process. So DI did not bring a significant change for children under 3 and for children with disabilities. So now we can see a clear equity agenda for the next phase of DI. And of course, this will have significant implications on the workforce, which today does not have the capacity to respond to the needs of these particular categories of children. So what was the force which was needed to reverse the picture of alternative care? We knew from the very beginning that there was a stringent need to bring new workforce in the social protection system. So to build its muscles to reach out to communities, to control inflow of children to residential institutions. Also, staff from residential institutions were seen as a potential new workforce. It didn't happen though at large scale, and we will talk about it later. The system needed foster carers, staff for family support services, and child protection specialists at different levels. This was for the social protection system and new workforce. At the same time, it was very important to use the long-standing workforce existing in other sectors at different levels, assigning new roles to them so that they can contribute to the DI process. And here we were thinking about authorities at all levels, about education staff for them to ensure inclusiveness of mainstream kindergartens and schools, which is indispensable for the DI process, professionals from all sectors to be a part of multidisciplinary mechanisms to address child protection issues, NGOs in their role of watchdog, role of service providers and for monitoring child rights, and also very much with mass media because we were thinking about changing social norms and about ethical reporting on child rights throughout the evolution of the DI process. This was our approach, to create new workforce and to use the existing workforce across the board and to invest in both of them. So this is the baseline, actually how we started. Social work non-existent as job and university training, local authorities with no capacity to assess needs and to plan and budget for services, no social workers to support families at the community level, staff in residential institutions working with no reintegration agenda for children, with no individual planning for them, nobody to do gatekeeping work, scarce human resources to provide family support services and family-based alternative care, no system to provide in-service training for social workforce, and also a lack of mechanisms to make other sectors contribute to the DI process, especially for prevention work at the community level. So this was back in the 90s. What we have now, and we are proud of it, we have social work. Social work has legal identity, and there are already several generations of graduates from 4 universities and 1 college training teaching social work. In some counties, local authorities increasingly invest in services for children and families. We have a nationwide network of social workers supporting families at the community level. It is 100% coverage. We will have child protection specialists in each community starting with 2014. We have a nationwide network of gatekeeping commissions. We have foster carers, but here the development is quite slow and we are concerned about it and we are looking into it, and also staff in over 130 daycare centers across the country. Looking across the board, education sector is currently building a new workforce to support school reintegration and inclusion of children with special needs. Inclusive schools and kindergartens are indispensable for the DI process. And in other sectors, if you look in other sectors, the existing workforce is implementing now new intersectorial mechanisms for addressing such issues as infant and under-5 mortality at home and child abuse and neglect. So this is the workforce that Moldova has as part of the system. We do understand that there is a way to go from existing workforce and to a well-functioning system. And we do have our justified concerns about the sustainability of the achieved results. As long as this workforce is very unstable, its capacity is still slow, its development is highly uneven across the country, the know-how on DI is still with a handful of expert NGOs which are dependent on external funding, and the transfer of knowledge and skills is quite slow. The real scaling up is not happening yet. NGOs
Hello. Thank you very much, Sylvia. I will go on from here. So I'm going to talk about a number of approaches that were developed and applied to strengthen social workforce in Moldova. So among these approaches, I will be talking about supporting the development of university curricula alongside in-service training to existing workforce, targeting multiple actors at different levels, recruiting and training new community workforce, retraining and redeployment of workforce from residential care, developing methodologies and support systems for the new workforce operation, developing intersectorial collaboration, supporting line ministries such as social protection, Ministry of Education to plan social workforce development, but also building capacity of NGOs as service providers. Social work was non-existent. Considerable efforts have been made to develop and unify social work curricula as well as method in 4 universities and 1 college. Also to develop social work ethical code, to strengthen practical aspects of the training, developing a system for students' practice placement in social services, but also to ensure that university training is informed by local level realities in terms of emerging social needs and practices. And in this, academia has been involved in good practice evaluation and dissemination as well as in workforce in-service training. And this was very important as practice development in Moldova was quite ahead of policy development or university training curricula development. The next approach is about targeting multiple actors. So child care reform requires collaboration of a number of stakeholders from different professions at the local, at district level, at national levels, including professionals from social protection, education, health, police and justice. Capacity building interventions focused on strengthening community level service provision, i.e. community social workers, their supervisors and managers, as well as on building capacities of multidisciplinary groups. Efforts have been made to develop inclusive education for children with special educational needs by training inclusive education managers and teaching support staff in each school. At district level, assistance was provided to build capacities of local authorities, child protection councils, social assistance, education, police and health professionals, gatekeeping commissions, service providers engaged in processes related to development of continuum of services, inclusive education, deinstitutionalization, and transformation of residential care. At the national level, interventions focused on building capacities of parliamentarian commissions for health and social protection, National Child Protection Council, policymakers from Ministry of Social Protection, Education, Health, Internal Affairs, Justice in order to support the development of child and family-friendly policies and legislation. In addition, the role of National Child and Family Alliance was strengthened to influence policy and service development processes in Moldova. New community social workforce development. The Ministry of Labour and Social Protection is leading this process. And the ministry was supported by a number of NGOs and development partners to implement a strategy for social workers planning, recruitment and training, undertake initial assessment, training need assessment of the newly recruited staff, and recruit and train a group of trainers to provide training to over 1,000 social workers at the community level, to develop and deliver a training program. Initial or basic training for social workers focused on social work methodologies such as case management, referral mechanism, communication, community mobilization, etc. And ongoing training consisted of modules for in-depth learning of social work methodologies, but also including specialized modules on a range of issues. The Ministry of Social Protection was also supported to develop social work methodologies and support systems such as case management and referral procedures, which were approved by the Ministry as working methodologies, gatekeeping mechanism to stop unnecessary entries of children in care, a supervision mechanism by which supervisors were recruited and trained, managers of the community social assistance service trained and supported to provide overall management of the service and supervision process. Training local multidisciplinary councils or groups to provide support to the community social workers and solving cases at the community level. A performance management system was introduced, and systems for accreditation of service providers and social inspection are under development at the moment. The next approach is about retraining and redeployment of residential care workforce. Strategies for retraining and redeployment depend on the type of the residential institution. From our experience, the most challenging is the redeployment of the staff from special needs institutions to community schools. And in Moldova, the Partnership for Every Child closed down 10 institutions so far, so special needs institutions seem to be the most difficult ones in terms of retraining and redeployment of the staff. Human resource assessment is essential as part of the institution assessment and aims to assess the staff chances for the redeployment, looking at staff qualifications, work experience, attitudes, behaviors, abilities to manage change, and also the willingness of the staff for redeployment. Training usually is provided at the beginning of the change process in order to reduce staff resistance. The training strategy depends on the transformation decision, either to close or to modernize the institutions. In both cases, the training program begins with change management training, and that's from our experience. If it's about the institution's closure, the training aims to support the personnel with redeployment and focuses around understanding the need for change, child developmental needs, alternative ways of meeting these needs outside of residential care. Training is about community and family-based social services, inclusive education. If the decision is to modernize the institutions, to improve the quality of the service, and this can be a temporary measure for a period of time before the institution will close down eventually, the training will aim at adjusting its operations to minimum quality standards and to new approaches to meeting children's needs. And in addition to the topics that I have already mentioned for closure of the institution, the training focuses on standards for residential institutions, child protection issues, child participation in decision-making and in the institution's life, work for child reintegration, for life skills development, living care programs. Again, from our experience, visionary, strategic leadership of the institution is essential for the implementation of a successful staff retraining and redeployment program. A retraining workforce to provide inclusive education. So, and that's a very important element in DI. So Ministry of Education was leading this process, but the Ministry was again supported by a number of organizations to develop a strategy for planning and training of school teaching support staff, to undertake initial assessments of the staff and develop a training program, to train managers for inclusive education in each school, to provide initial and ongoing training of teaching support staff to work with children and other teachers for curricular adaptation and modification, but also train members of the district psychopedagogical assistance service to assess and support schools to meet children's special needs. The Ministry of Education was also supported to develop a normative and methodological base for the workforce activity, such as establishment of school resource centers to be used by teaching support staff and children, development of regulation for the psychopedagogical assistance service, development of financial norms for inclusive education. A new approach is training community actors to work together or developing an inter-agency collaboration mechanisms. There have been a number of interventions focused on the development of multidisciplinary approach in DI and in child care and protection, such as training nurses and social workers to work together in order to support families with children under 5 for early intervention and to decrease the infant mortality rate in the country. Another initiative was about training social workers, mayors of the villages, as well as school, health, and police professionals to implement protocols for interagency collaboration on cases of child abuse and neglect. Training of district decision makers to oversee the community interagency work. Training community actors to mobilize resources to provide improved support to children and families, but also training for the development of partnership and service provision between public and private sectors, including civil society organizations. Some lessons learned from this. Capacity building using a holistic approach can improve skills, change attitudes and behaviors, and increase reform momentum. Changes in knowledge, attitude, and practice produce sustainable impact in child welfare reform, and this impact includes a sense of improved quality of services expressed by stakeholders. In Moldova, considerable improvement was achieved in social workers' professional competencies. They are so rich in the community, the collaboration with other actors and services in solving various cases. But the biggest impact was that the social workers have changed their attitudes towards beneficiaries, job responsibilities, and their colleagues. Another learning is that regular and structured training in combination with regular and structured supervision produce a positive impact on staff performance. Supervision was instrumental in the transition from accumulating to applying the knowledge. And it is also important in the conditions of intense social workers' caseload in Moldova, unfortunately. The training for community social workers should be very practical. That's our learning. Should be very flexible and should provide them with enough hands-on experience, expose them to enough level of activity, and encourage developing and practicing new skills. Follow-up sessions are essential as they help sustain the effect of the original training and supporting the continued use of learned information and skills. Training evaluation, training and impact assessment are key in order to make sure that invested resources lead to an adequate quality of the activity, meeting the needs of the beneficiaries. And social workers' annual performance management enhances their professional growth and leads to improved service quality and should become a nationwide practice in Moldova, which is not at the moment. Some key success factors in the process of developing of the social workforce, quite similar probably to what Delia has already mentioned. Strong partnership with ministries, with local authorities, with frontline practitioners, and academia is very important. Leadership of the line ministries is essential in this process. It's very important that NGO coordinate capacity building programs and that they provide letting expertise and investing in human resource development. It's very important that the government receives assistance to plan social workforce development. Another key success factor for Moldova was that training was informed by practice development and using results from practical implementation of services, systems, approaches. Another key success factor was that we were using good performing local authorities to share their knowledge and expertise and thus encouraging development in other regions of the country. Having finance departments and Ministry of Finance on board in order to secure training financial sustainability is very important, but also working with politicians, especially in the district councils, to increase their understanding of new services and HR development issues. Another one is that we had a donor support to the DI and also to the social workforce development processes, and that there was harmonization of donors' agenda around country's priority. And the last slide is about our future priorities, which basically represent our current challenges that Silvia has already mentioned some of them. So for us it will be very important in the nearest future to ensure the quality of children's services is improving by applying the new knowledge learned by different stakeholders in child welfare reform, to ensure knowledge transfer from a number of big NGOs to state stakeholders in child care reform, but also to grassroots organizations that can provide support to children and families at the community level. Ensure uniformity in applying social work methodologies and in social workforce development across the country. The status and role of community social workers need to be promoted to address issues related to high turnover rates, low motivation of community social workers, strengthen professional supervision as a measure to ensure social workforce development, as well as to ensure financial and institutional sustainability of the workforce development processes. It's very important that reallocation of funding from residential care to community and family-based care also includes funds for the workforce development, which is not happening at the moment, unfortunately. And one more priority will be to strengthen and ensure financial sustainability of NGOs as service providers, but also as providers of capacity building programs. We need a system to be developed whereby local and national authorities purchase training from NGOs and local authorities commission social services to NGO and private sector. Thank you very much.
Okay,
I hope
thanks
it
very
wasn't
much.
too hard on you. Being the last one, even though it's quite difficult. So I'm happy to answer questions together with Silvia. Here you can see a number of resources that you could
questions around the community
have a look at.
level.
In order to have a better picture about what is happening in Moldova in terms of
how
GI
is training
and
for community social workers delivered and over what period before they qualify, and what challenges have you met while establishing the community social workforce? So
I can start with, and Silvia can help me, probably. I think that having the network of community social workers is one of our biggest achievements, and it is really about reversing the pyramid, as Silvia has shown, to investing at the community level in order to prevent a number of issues that can lead to the separation of children from their families and placement in residential care. I have to mention that this process of recruiting 1,200 social workers was a very complex one, and as I said, the Minister of Labour and Social Protection was leading on that, but there were many actors that were contributing to this process. So the first phase was when the first recruits back in 2007 received an initial training in social work. And we have to tell you that that was quite complicated because the first recruits were not really from the social work background. So they were people from different other professions, like medical doctors, nurses, teachers, and there were other professions there. So it was very important to provide a basic training to them that would not scare them, but would allow them to start at least doing their work at the community level. And then to introduce an ongoing system for in-service training, introducing new modules of training which became more and more specialized. Of course, it was, a very radical decision at that point in time, and you can imagine that this is really about shifting resources to community level. So in order for this to happen, I see questions here, how this happened, was really about, coordinated advocacy and communication between a number of development partners, like every child at that time, including and with UNICEF and other organizations, managed to get the attention of the very high-level politicians in Moldova about the situation of children in the residential care. And at that point in time, back in 2006, there was a presidential order to start thinking about deinstitutionalization and developing the first, strategy for DI, which had a number of strategic priorities at that time. One of the priorities was community social workers, employment of community social workers to provide primary family support services at the community level. The second one was about introducing a gatekeeping system to stop unnecessary entries of children in residential care. The third one was about alternative care, so foster care started to be developed at that point in time. Reallocation of resources from residential care to community-based social services, and of course capacity building program to cover all the stakeholders in child welfare reform. So I see Hugh is asking about high turnover of staff. It's quite complicated. I think it's relevant for all of the countries, not just for Moldova. It's quite complicated to retain social workers at the moment, but at the same time we have to see that, we have to understand that community social workers at the community level there are not so many job opportunities. So being a social worker is much better than to not to be engaged in any work at all. So there are a number of people that really stay in jobs. And with some motivations like capacity building program. Recently a financial motivation was also added, so finally we've managed to convince especially the Minister of Finance to increase their salaries. So I think that is very, very important. But as we said, a new workforce is coming starting with January 2014, community child protection workers, which again shows a very high level of political commitment to strengthening of community workforce. So we're talking about the same number of child protection officers, about 1,200 child protection officers at the community level that will be recruited back starting with January 2014. And of course there will be again a big investment into capacity building programs
but there are questions, and I think
new workforce in the
doing, and if you can stay on, that's great, and if you have to leave, then that's fine. But we did have a couple of sort of wrap-up questions. One was directed at Moldova, but it probably applies to Rwanda also, and that is that what you described in Moldova, starting with university, supporting the development of university social work training, targeting multiple actors, looking at the community level, retraining the workforce, a lot, very comprehensive. And I'm curious about what coordination is always an issue when you're
Can I interview now? Hello, can you hear me? Back in 2007, when the social workers network was created, in parallel, UNICEF
Yeah. Moreover, I think it's very important that, as I mentioned, that it's very important that the line ministry is leading the process. So back in 2007, a donor harmonization social protection group was created. It's like a donors and NGOs group that is trying to harmonize their agendas around government priorities. So it was established back in 2007, and it's still very active, where the Minister of Social Protection presents their annual development plans for different areas of their work, not necessarily just for the workforce development, and where different donors and NGOs are trying to coordinate
If I Yes. Thank you. Yes. Wonderful. Thank you so much. I just want to highlight that what Stella mentioned with regards to the development of the social workforce in Moldova is extremely relevant and very similar in Rwanda, maybe at a different point in its development. It's about contextualizing the theoretical base, embedding it in the national context, involving the national training authorities, but also that kind of cross-learning across various professional and paraprofessional groups is equally important. I just want to highlight, because I think John asked a very important question in terms of the lessons learned of what kind of changes led these governments to make their decisions into reforming the child protection system. And I would like to highlight 4 key elements that, in my experience working across these 15, 20 countries in different contexts, represent almost like a trend. And I think the 4 key ingredients for success and government commitment, but ultimately for the success of the child protection reform, are represented by the existence of political will, and that political will is
Okay. Thank you, Delaney. Thanks for both responses, both in terms of reinforcing some ideas around coordination mechanisms and for summarizing the 4 critical variables in response to John's question. Great presentations, a good discussion. Yeah, I was going to turn it over now to
Thanks, Jim. Thanks so much. Also to Delia, Sylvia, and Stella for their really comprehensive and fascinating presentation, and also to the participants for their question, and thank you for your patience with some of the technical problems we've had. Briefly, because we're running a bit over time, I just want to say that listening to this presentation on what deinstitutionalization actually means in those 2 countries brings to my mind the fact that deinstitutionalization is as much about transforming people as it is about transforming institution or system. From listening to the speakers, you could see that the process is totally dependent on having a workforce that's willing and able to do things differently, to change their relationship to children and families, to use different ways of working, learn different skills, to train, take on new roles and responsibilities. So much is reliant on their being ready to engage and play a key part in this change process and the new child care and protection systems that come with that. I really liked Delia's reference to it as the social workforce as being the glue. I think it's a great image, and I think this presentation really highlighted that. And that also means that it highlights the fundamental role of social work education and training to actually support that shift towards child and family-centered services and prepare the social service workforce to develop and deliver very different approaches to residential-based one. As the speakers have highlighted, that also means unifying social work methodologies, but also ensuring the quality and something highlighted by all speakers, the practical nature of the social work training is absolutely key. So I think the learning about the reform of social work education, training, certification, and practice in these different contexts is absolutely key, as we've heard, to the strategies to reform alternative care systems for children, but also to strengthen child protection system. That's really what came through to me listening to this presentation. As you will see, a number of resources have been shared by the speakers about these transformations and the lessons learned from them. We really encourage you to look at them. They are both on the Alliance's website, also, of course, on the Better Care Network website. And we really encourage you to have a look and read them. Just a few reminders before we close the session. Please do let us know if there's any events or opportunities that you would like to announce. You can type them in the chat room. Also, if you're interested in joining the Alliance and receiving notices about future webinars, you can see on the slide the website. Similarly, with the Better Care Network, for those of you who don't know the Better Care Network, I encourage